being recorded.
All right, so welcome everyone tonight to our webinar. So this event is open to all healthcare professionals interested in the care and the science of multiple sclerosis. Of course, it's targeted towards nurses, but not only nurses, to also pharmacists and also to doctors who would also like to join us, all our colleagues taking care and passionate about the care of MS patients and all people living with multiple sclerosis, and also to caregivers of those living with MS as well. So we titled our webinar tonight, Upgrading the Standards of Care for Multiple Sclerosis. And this event is hosted by the IVPN, the network you've all come to know, targeted towards neuropsychiatry and specifically towards MS as well. We're happy to say this event is endorsed by the Consortium of MS Centers, who has supported our events really thoroughly, the multiple events we've done through our region. So thank you for the CMSC, whose CEO, June Halper, has been really a mentor for all nurses in the region. So thank you so much. And also, thank you for our supporters from the industry, specifically to Novartis today, for really supporting and sponsoring this event today and making this educational activity possible tonight to all our nurses. I'm happy to have experts joining us tonight from locally. First, Gina Lee, thank you so much for joining us tonight. Regionally, thank you to Dr. Maya Zainuddin. Miss Gina Lee first, of course, thank you so much. To Dr. Maya Zainuddin, thank you so much for joining us tonight to give your expertise. And internationally, thank you from the bottom of my heart to Dr. Yolanda Wheeler for accepting to be with us tonight. I'm happy to introduce you to all our speakers one by one as we go through the night, through our talk, which will be from almost 8 to 10 p.m. today. UAE time. Of course, I know everyone is joining us from probably all over the world, I'd say, because I know we cater to the region and the world, hopefully, as well. So I know people are joining us as we go. So without further ado, I will start with our first speakers for tonight. Our topics will range from, covering epidemiology of MS. We'll also talk about treatments for MS. We'll delve a little bit deeper into pediatric MS. We thought this is a very interesting topic for us and really wanted an expert, which is why we brought on Dr. Yolanda with us tonight. And I'll also end by talking about B-cell therapy specifically. So let me first start by introducing our first speaker for tonight, Ms. Gina Lee. Thank you for Gina for accepting to be with us tonight. So to give you a little bit of introduction about Gina. So Gina has been a multiple sclerosis nurse coordinator right here in Abu Dhabi at the Cleveland Clinic for at least for the last 3 years. She has been very busy coordinating care for patients living with MS, for people living with MS, in a very busy practice, of course, at the MS Center in the CCAD, the Cleveland Clinic of Abu Dhabi. Where she really coordinates the care of MS patients, ensures a very thorough plan of care is followed. She follows up the patient's results from, making sure everyone's results are being followed up on time, monitoring how patients are doing with their disease-modifying therapies, reviewing their plan of care, and most importantly, doing what nurses do best, which is really educating patients throughout their visits when they're following up with their nurses. Of course, she also participates in educating as well her fellow nurses. So Gina will first speak to us tonight about the epidemiology and pathogenesis of multiple sclerosis. So not to delay any further, I'll give the floor to Gina to start her talk tonight. Thank you, Gina.
I'm not sure if Gina has technical issues, and probably we can start by someone else. We can shuffle just the presentation.
Okay.
Meanwhile, we'll be resolving her technical issues. So I can give my lecture and then she can give her lecture after.
Sure, no problem. Okay, so I'll start, I guess, by introducing you then.
Yeah.
So Dr. Maya Zainuddin. So I know a lot of you know Maya as well. Maya has been working in the field of MS since more than 12 years. Maya has been the first certified MS pharmacist since she sat for the exam, the multiple sclerosis certified exam several years ago, and became the first MSCS pharmacist in the region at least like more than 10 years ago, I would say. So since then, Maya has been really very thorough in working on research and clinical practice. So first, her experience started at the American University of Beirut Medical Center, where we opened the first multidisciplinary MS center in the region. And since then, she started taking care of MS patients in the region. After that, she committed her work to research mainly, publishing and working in multiple international clinical trials in the region. After that, she started working as well in the MINAC-TRIMS, our regional TRIMS organization, where she has been the executive secretary since then. And in the last few years, she has been working on her PhD in neuroepidemiology at the University of Limoges in France. So tonight, Maya will be discussing updates in the treatment of relapsing remitting MS. And since it's a very always topic that raises a lot of questions, and there's always lots of updates in it, and also it's usually a rich topic. So I'll let Maya immediately start, and we'll leave the questions at the end of each topic. So you will have the chance to ask each speaker topics right at the end.
Thank you, Joelle, for this kind introduction. So let me start by sharing my screen. Okay, can you see my slides?
Yes.
Okay. So as Joelle mentioned, I will be discussing today the updates in the treatment of relapsing remitting multiple sclerosis. So disease-modifying therapy for MS, they are relatively new. So a multiple sclerosis as a disease was first described in 1838 by Carswell. and he identified the demyelination process in the brain. And then in 1868, Jean-Martin Charcot defined multiple sclerosis as, or what they called sclerose en plaques in French, as a demyelinating autoimmune disease of the brain. However, if you look after the definition of the disease, it took quite some time to start having some approved treatment for this disease. However, despite that, so the first DMT was introduced in like 1993, and those were interferon. However, these DMTs, the era of and the development of DMT have been rapidly advancing over time, and as you can see, the number of DMT have been increasing exponentially since 2011. And as of 2021, we had more than 19 approved branded multiple sclerosis DMT in the United States and in Europe as well. And as you can see on this chronogram, really the era of MS treatment started after 2011 with the approval of the first oral DMT for the treatment of MS, which is fingolimod. And then we had many other medication that came through. We had the IV medication like natalizumab, alemtuzumab, ocrelizumab. We have more oral treatment that have been approved since that, dimethyl fumarate, teriflunomide, cladribine, and we have the traditional interferon or subcutaneous injectable, which are interferon and glatiramer acetate. And really the treatment of MS are still emerging, and we have more therapies coming up in the pipeline, and those are mainly the anti-CD20 monoclonal antibody and the BTK inhibitors. So what do disease-modifying drugs do? They all decrease the frequency and the severity of the relapse. They decrease the number of lesions on MRI, and they probably slow the disability progression. So keep in mind that those medications will not cure the disease. So MS until today is not a curable disease. We can stop the progression of the disease. We can maintain the patient in remission, but we cannot cure the disease. It will not make the patient feel better. So those are not symptomatic therapy. If the patient has, for example, urinary problems, spasticity, numbness, starting a disease-modifying drug will not make him feel better. And it's very important for you as nurses to set all these treatment expectation with the patient before he starts any therapy, and to set realistic goal with him. And also all these medication will not alleviate his symptoms. What are the goals of therapy? And again, it's very important for you as and it's part of your role as nurses, as MS nurses, to define the goal of therapies for MS patients. So we have three goals of therapies. First of all, to modify the disease course by decreasing the number and severity of relapses, decrease the accumulation of lesion, and slowing the disability progression. And here comes the role of disease-modifying therapy. And the second goal is to treat the relapse on short-term as need basis. So whenever the patient will experience any relapse or attack, we administer usually a course of IV or oral solimedrol in order to alleviate the symptoms and ameliorate the symptoms of relapse faster. And the treatment of relapse, which is usually and commonly steroid, will not have an impact on the disease activity or on the prognosis. So it will not change the progression of the disease. The third goal of therapy in MS is to manage the symptoms associated with the disease. So to decrease the symptoms like fatigue, tremor, pain, spasticity, stiffness, urinary problem, depression, all these MS symptoms. And we have several drugs on the market that target all these symptoms. And again, these drugs do not have any direct impact on the disease activity or disease progression. So for the sake of the presentation, I will be only discussing the first goal, which is to modify the disease course by using disease-modifying therapy. So how can we achieve this goal? Several mechanisms of action have been explored. So we have many diverse options of disease-modifying therapy, and each drug has a different mechanism of actions. Some of the drug will work on the DNA synthesis. They will inhibit the proliferation of T cells, and T cells are those bad cells who will cause the inflammation in the brain and the damage, and therefore the inflammation and the disease itself. Such a drug are teriflunomide and cladribine. Other drug will are S1P modulators, so they will downregulate the S1P receptors, they inhibit the aggression of the lymphocyte from the lymph node into the peripheral circulation. So they will prevent the migration of the T cells from the lymph node where they are trapped into the circulation, and therefore these T cells will not circulate in the periphery, and therefore will not enter the central nervous system and will not cause damage. And those are the S1P receptor modulator, fingolimod, siponimod, and ozanimod. Other drug, they actually kill B cells. They cause B cell depletion. Those are the anti-CD20, ocrelizumab, ofatumumab. Other drug, they kill both B and T cell, and those are alemtuzumab. We have also natalizumab, who work on the blood-brain barrier, and it prevents the adhesion of T cells into the blood-brain barrier, and therefore prevent the migration of those inflammatory cells into the central nervous system. So all the cells will stay in the periphery and will not enter. So it actually closed the blood-brain barrier. And we have other drugs that are anti-inflammatory, or what we call immunomodulator drug. They will not cause immunosuppression or kill cells, but rather they will work on the ratio between the T helper 1 and the T helper 2 cells, and those are the good cell and the bad cells. So they will work on this balance. They will increase the T helper 1, and they will decrease the T helper 2. And we have other drug, those fumarate drug that work on the oxidative pathway. So they increase antioxidation and decrease inflammation. Those are the disease-modifying therapy that are FDA approved for MS. So I grouped them for you by mode of administration. So we have the injectables, glatiramer acetate, the interferon beta 1A, interferon beta 1B. Those are either intramuscular or subcutaneous injection, and they are auto-injectables, the self-injectable. The patient will take the injection him or herself at home. We have also the newly approved injectable, which is ofatumumab or Kesimpta, and this is an anti-CD20 monoclonal antibody that is also given subcutaneously at home. The patient can take the injection. We have the oral therapy, dimethyl fumarate, fingolimod, teriflunomide, cladribine, siponimod, ozanimod, and ponizimod. And we have the IV drug, which needs admission to the hospital or visit to the MS center to be administered, and those are alemtuzumab, ocrelizumab, natalizumab, and mitoxantrone. And very recently, in April 2023, iblitiximab, which is Briumvi, it's an infusion, it's an anti-CD20, also monoclonal antibody, IV, was also recently approved and added to this list of approved DMT. I will be discussing this medication in terms of how they are used. So I will be dividing them into first-line therapies and second-line therapy. So first-line therapy are drugs that we usually start as first-line up in diagnosis in patients with mild to moderate disease. So those are injectables, the traditional injectables, interferon and glatiramer acetate. They are all FDA approved for relapsing remitting MF. They differ by the frequency and the route of administration. So for example, interferon beta 1A is given once weekly as IM injection. The 1A is another one is given subcutaneously 3 times per week. So it's 12 injection per month. We have the 1B, which is given every other day subcutaneously. It's 15 injection per month. We have the glatiramer acetate, which is given daily injection subcutaneously. They all have the same efficacy, which is around 30%. They decrease the relapse rate by 30% in clinical trial compared to placebo. We have a new kind of interferon that was introduced a few years ago, which is the pegylated interferon. And this is an injection given subcutaneously every 2 weeks. So what they add, they pegylated the interferon, they add a new molecule or protein that will prolong the circulation of this protein, leading to stabilization of the molecule and leading to longer half-life. So it will shield this interferon or this drug from degradation by the liver enzyme, and it will stay in the circulation, and this will lead to decreasing the frequency of the injection to every 2 weeks. It has, despite decrease in frequency, it still has the same efficacy than the other injectable interferon, and it will decrease the relapse rate by around 30%. All these injectable, they have a common side effect profile. They all cause flu-like symptoms, and here comes your role as nurses in order to educate the patient how to prevent or cope or decrease this side effect by advising your patient to gradually start with a low dose and increase the dose gradually, pre-medication with ibuprofen or acetaminophen before half an hour before the injection, take the injection at bedtime, reassure the patient that these symptoms will diminish with continuous use of the medication. The other common side effect of interferons are the injection site reaction, which is the redness or the bruising at the site of injection. And again, here come your major role as nurses or pharmacists in training the patient on how to take the injection in the right technique, how to clean the site of injection, how to rotate the site of injection. So we should rotate site of injection and do not perform 2 consecutive injections at the same site. And finally, we need to advise our patient or monitor our patient. And what we do is usually CBC at baseline, at 1 month, at 3 months, for 1 year, and then every 6 months. Although it's an immunomodulator drug and it does not cause immunosuppression, but we need to look, in some cases, we had some drop in the lymphocytic count. So we need to monitor for that. And all this medication, they are cleared by the liver. So we need to monitor liver enzyme. Also, very rarely, interferon can cause hypo or hyperthyroidism. So we need to check the TS thyroid level every 6 months in patient with history of thyroid dysfunction. And whenever the patient reports weight of loss or weight gain or any change in his weight without changing his diet. Teriflunomide, it's a once daily oral immunomodulatory drug approved for relapsing remitting MS. What do it inhibit the dehydroorate dehydrogenase enzyme, which is a key mitochondrial enzyme in the synthesis of pyrimidine, which is required for the division of and proliferation of B and T cells. So what teriflunomide will do, it will inhibit this dehydroorate dehydrogenase enzyme, and it will prevent the proliferation of B and T cell. It has the similar efficacy to interferon, around 30% decrease in relapse compared to placebo. Safety profile, it's well tolerated. It can cause increase in liver enzymes, some hair thinning, so some hair loss, which will improve with continuous use, and some diarrhea. Usually we monitor CBC and liver enzymes similarly to interferon with teriflunomide. We screen the patient for TB before starting teriflunomide, because in the study it can lead to reactivation of tuberculosis. And teriflunomide is the active metabolite of leflunomide, which is a drug used for a long time for rheumatoid arthritis. So we know really about it's over the long term, it's a safe medication. Moving to the other first-line oral DMT, it is the dimethyl fumarate. It's a capsule given twice daily. It's an oral immunomodulator. As I mentioned before, it is an antioxidant, and it increases the antioxidant response in the nucleus of the cells and decrease the inflammatory response. It's come as a dose of 240 milligram. Usually we start with a low dose of 120 milligram twice daily, and after 1 week we increase to the 240 milligram twice daily. Also, it showed that it decreased the relapse rate by 50% compared to placebo in original in phase 3 clinical trial. As side effect, it has gastrointestinal side effect, mainly nausea, diarrhea, abdominal pain, and the flushing, which is this redness that occur usually after the intake of the medication. So the prevalence of the GI tolerability is usually highest in the first 3 months, and then it will decline with continuous use of the medication, and similarly for the flushing. Again, dimethyl fumarate, it's a new drug. It was a new drug initially in the MS, but we know about its long-term safety because Fumaderm is a drug used for psoriasis in Germany since 1994. The first oral DMT that was approved in MS was fingolimod, and fingolimod can be used as first line and as second line therapy because it has a higher efficacy than the traditional injectable. It's a once daily oral medication, and it is an S1P receptor modulator that will prevent the migration of the lymphocyte from the lymph node. So it will trap the lymphocyte in the lymph node. It will not kill the lymphocyte, and it will prevent their circulation into the CNS. It has, as I mentioned, a high efficacy of around 54%, 52 to 54% decrease in relapse rate compared to placebo in the initial clinical trial. In terms of safety and monitoring, we need to perform a CBC before starting a patient on fingolimod, liver enzymes and bilirubin level. We should obtain varicella zoster antibody, and if the patient is not immune and his or her antibody are negative, we need to give the vaccine, and then after 1 month recheck the VZV antibody. Once they are positive, we initiate fingolimod, and this is because fingolimod can reactivate varicella zoster infection, and there was 2 cases of death in the clinical trial of fingolimod, and that's why it's recommended to make sure that the patient is immune before starting treatment. Also, ophthalmic exam need to be done because very, very rarely, less than 1%, fingolimod can cause macular edema or edema in the macula on the macula in the eyes, and that's why we need to rule out that the patient doesn't have macular edema before starting fingolimod. EKG, fingolimod can cause bradycardia, again in very rare cases, and that's why we need to do an EKG to rule out any cardiac abnormality before starting fingolimod, and we need for this reason to administer the first dose at the hospital. And of course, pregnancy test because it's contraindicated in pregnancy. As I mentioned, the first dose need to be administered in the hospital, and we should obtain vital signs every hour, blood pressure and heart rate. It should be monitored for 6 hours after the first dose is administered to detect any decrease or bradycardia and decrease in heart rate, or what we call bradycardia. Then the patient can be discharged home and can continue his medication safely. In terms of monitoring, we need to monitor CBC, liver enzyme, and ophthalmic exam after 3 months of initiation, then CBC and liver enzyme every 6 months, as long as the patient is on fingolimod. The recent S1P modulator that was approved was ponizimod, and ponizimod is a more selective S1P receptor antagonist that will downregulate only the S1P1 receptor. So it comes also as a tablet. Usually the dose is 20 milligram. We start with a low dose and we titrate the dose gradually over 15 days until we reach the 20 milligram dose. It can be taken with or without food. And as I mentioned again, it is a once daily drug. It showed also decrease in the relapse rate by 30.5% compared to teriflunomide. So the study, the optimum study, which is the phase 3 clinical trial of ponesimod, the comparator was not placebo, but rather teriflunomide, which is an active comparator. It also decreased disability progression by 16% compared to teriflunomide. So it was effective and it was superior to teriflunomide in terms of efficacy, and it was well tolerated with a similar side effect profile than fingolimod. Moving to the second line therapies, we have cladribine, which is again an oral therapy, but it is an immunosuppressive one. So what cladribine does, it actually kills most of B and T cells. So as you can see, the orange one are the autoreactive T cells, B and T cell, and as you can see, it will kill most of them. And then our immune system will be able to reconstitute a new set of B and T cell with less autoreactive T cells. So this is the mechanism of action. So it actually kills B and T cells, and it has a high efficacy. It decreased the relapse rate by 58% compared to placebo. So usually cladribine is given over a period of 2 years. So 2 cycles, the first year, it's given over 5 days. This is cycle 1. And after 5 weeks, we give cycle 2. So it's a total of 10 days per year in year 1. And then we repeat the same treatment course in year 2. And then we monitor the patient and we don't administer further dose, or we don't treat the patient with any other DMT until the patient has breakthrough disease. And most of the patient, actually, the long-term follow-up of the cladribine patient showed that over a 10 years period, actually 77.8% remained stable after 2 years of treatment of cladribine and didn't need to be started on any other therapy or to take a 3rd or 4th cycle of cladribine, whereas 75.6% of the patient need to take a 3rd or 4th course of cladribine. Moving to siponimod. Siponimod is the new selective S1P receptor. What is special about siponimod, it is the only drug that was FDA and EMA approved for the treatment of secondary progressive MS, and it was the first one approved for this category of patients. So all the medication that we have on the market or DMT, usually they target relapsing remitting MS patient. So it has the same mechanism of action as fingolimod, but it's more selective. It has high potency on S1P1 and S1P5 receptor into the brain. And because of more probably effect on the brain, we think that it inhibits the aggression of lymphocyte, as I mentioned, and it may promote a neuro repair mechanism within the central nervous system. And from here, it might play a role in secondary progressive MS. So this is the EXPAND study, which showed that it actually stopped effectively and statistically significant. It stopped the progression of the disease compared to placebo by decreasing the disability progression by 26% compared to the 6-month disability progression by 26% compared to placebo. And based on the result of this EXPAND study, it was approved for secondary progressive patient. And here you can see that whenever they looked at subgroup, so if for all subgroup, regardless in male, in female, if they are previously treated with interferon or any other DMT, and regardless of the number of enhancing lesion on brain and MRI, the age, the baseline disability, actually siponimod showed superiority compared to placebo in secondary progressive MS. Also, it showed it decreased or it improved the cognitive function in SPMS patient, and this is very important. And cognitive actually impairment is an early sign of progression in MS, and there was overall a risk reduction in the in the SDMT score, which is the test used for cognitive to test cognitive processing speed, by more than 4 points compared to placebo. And this again highlight the efficacy of siponimod in SPMS patients. Moving to natalizumab. Natalizumab is an intravenous medication. It was the first monoclonal antibody that was approved for the treatment of MS. It's intravenous drug given every 4 weeks as a 300 milligram dose. As I mentioned earlier, it prevents the adhesion of the B and T cell in the blood-brain barrier, and it will prevent the migration of the lymphocyte from the periphery into the central nervous system. So this is the mechanism of action of natalizumab. It showed a significant decrease in the relapse rate by actually 67% compared to 67% compared to placebo, and also for the disability progression, it showed decrease in disability progression by 42% compared to placebo in the phase 3 AFFIRM study. And this is those are the result of the long extension study, which is the top, which showed that natalizumab maintain its long-term efficacy even when used over long period of time. You can still show that the relapse, the annualized relapse rate still remained decreased and remained low over 10 years of use of natalizumab, and this highlights the sustained efficacy of the treatment. Natalizumab carry risk of progressive multifocal leukoencephalopathy. It's one of the very serious side effects of natalizumab, but it's a rare one, and if you look at the incidence, it was 4.18 per 1,000 patients as of 2017. So it's a very rare side effect. Natalizumab, by decreasing the or by immunosuppression that it causes into the central nervous system, it can lead to reactivation of some opportunistic virus, and one of these viruses is JC virus, which remains dormant in the brain. And once we use drugs like natalizumab, it will wake up and it might cause demyelination and into the brain, and it can lead also to disability, and if not detected early, it can even lead to death. So really, it's a serious side effect, but it's very rare. However, if we know what are the risk factors for PML, and if we monitor the patient closely for this side effect, we don't have to worry about it. So the 3 major risk factors for PML are the duration of treatment. So more than 2 years of treatment with natalizumab increase the risk of PML. Prior treatment with immunosuppressive drugs. So if we use other immunosuppressive drugs like cladribine, for example, anti-CD20, this will increase the risk. And the positive serum JC virus. So if we test the patient and the patient actually has positive JC virus, so this will lead to increased risk of this infection. So, and because of this infection, the risk of this infection, natalizumab can only be given under a restricted distribution program, a risk management program, which is the TOUCH, and it can only be administered in MS center and in hospital under the supervision of clinician. And in clinical practice, that's why it is reserved as second line or in aggressive relapsing remitting MS patient. Moving to another monoclonal antibody, which is alemtuzumab. Alemtuzumab is also another immunosuppressive drug that will select almost, it's an anti-CD52 that will bind to all B, mostly all B and T cells, and it will kill them. So it will deplete B and T cells through antibody-dependent cellular cytosis and complement-mediated lysis. And then our immune system, after 1 month of depletion, will start to repopulate a new immune system or a new set of B and T cell free free of multiple sclerosis or not autoreactive as the original B and T cells. So in the CARE-MS1, which is the phase 3 trial, it significantly decreased the relapse rate even in treatment-naive patients. So in patients who did not tried any other treatment, it decreased the relapse rate by 55% compared to interferon in treatment-naive patient. And also, in CARE-MS2, it decreased the relapse rate by 50% compared to interferon, and those patients who were treated previously and who failed other drug and who were shifted to alemtuzumab. So it was effective in both treatment-naive patient and patient failing therapy. And alemtuzumab it's an IV medication given also over 2 years. So the first year, the patient will take 5 consecutive days of alemtuzumab. The second year, he will take 3 consecutive days, and then the patient will be monitored. And whenever the patient develop any breakthrough activity, relapse, a new lesion, we will administer the third or the first course. And the extension study of alemtuzumab showed that also almost 70% of patients, they did not need to receive any additional therapy through year 4. However, with this good safety profile comes an aggressive side effect profile. So given this aggressive immunosuppression, alemtuzumab can cause infusion reaction, it can cause infection, it can cause other autoimmune side effect, mainly autoimmune thyroid disease, immune thrombocytopenia, and nephropathy. And that's why it needs very close monitoring, and patients need to do on monthly basis blood test and urine analysis even when he is not treated. So even after completion of the 2 years of treatment, the patient need to do a monthly test for almost 5 years. The other DMT that were just emerged a few years ago are the anti-CD20 or this B-cell therapy. And really the role of B-cells was highlighted recently in the pathogenesis of MS. So traditionally we knew that MS is a disease of the T cells, but nowadays not anymore. This concept has changed, and we know that B-cells now play a major role in the pathogenesis of MS by interacting with autoreactive T cell and enhancing the inflammation. And ocrelizumab was the first anti-CD20 that was FDA approved for the treatment of MS. And also what is special about ocrelizumab, that it was shown also to stop disability progression in patients with primary progressive form of the disease. And it was the first drug approved for primary progressive MS. So in the OPERA 1 and OPERA 2, those are the study performed in relapsing remitting MS patient. It decreased the relapse rate by 50% compared to interferon beta. This is the oratorio where they tested ocrelizumab for primary progressive MS, and it actually decreased the disability progression by around 25% compared to placebo. And based on the study, it was approved for primary progressive MS. It is given intravenously as an infusion in the hospital, so patient has to be admitted in the hospital every 6 months. The most recently and the new anti-CD20 approved for the treatment of MS is ofatumumab. And actually ofatumumab is the first fully human monoclonal antibody that has been investigated for MS. So look at the monoclonal antibody. We have rituximab. Rituximab, it has a part chimeric. Chimeric means that it comes from the mouse. It contains some mouse sequences, and the other part comes from the human. Ocrelizumab has some mouse sequence, but to a lesser extent than rituximab. However, ofatumumab is a fully humanized anti-CD20 monoclonal antibody. What does this mean? It will bind to a different CD20 epitope compared to rituximab and ocrelizumab, and this means that it has better efficacy and more favorable siding effect effect because it will have an increase in the binding affinity compared to rituximab and ocrelizumab. It also showed it was a very effective medication. It decreased the relapse rate by 50.5% compared to teriflunomide and by 58.5% in the Asclepios 2 trial, also compared to an active comparator, which is teriflunomide. It was very well tolerated. The major side effect of the common side effect of ofatumumab is the injection site reaction. So really the side effect were well balanced between the teriflunomide and the ofatumumab, and there was no risk of any malignancy, serious side effect, or any adverse event leading to hospitalization. So really we have many choices for as DMT for the treatment of MS. How do we choose? So usually it should be a shared decision between the healthcare professional, the physician, and the patient. And who will help the patient take this decision is you as nurses, by discussing the efficacy, the safety, the tolerability, checking the needs of the patient, what is best for him, taking an oral drug, coming to the hospital every month, every 6 months, or taking a high efficacy injectable like ofatumumab at home on monthly basis. So really all these factors should be taken into consideration, of course, in addition to the cost and what is covered by insurance, before choosing any DMT for a patient. And with this, I will end my presentation. Back to you, Joel.
Thank you, Maya, so much for the comprehensive start to our talk. So let's see if we have some questions. We do have some questions. So I think someone's asking, so if these medications have any interactions like pharmacokinetic and pharmacodynamic interactions, and if any of these medications are inhibitors or inducers of the CYP450 enzyme.
Okay, so of course, if the patient has multiple comorbidity, especially if the patient has some cardiac disease, taking drug that cause QT prolongation. So for example, whenever we start him on S1P receptor modulator, which might have some effect on the heart, it's better to always check those drug-drug interaction. But in general, the DMTs does not have major drug-drug interaction. They are not like anti-epileptic CYP inhibitor and CYP inducer. We don't have this problem with MS, but it's always we should always check whenever the patient is on a polypharmacy. It's better to check for any serious drug-drug interaction, but we very rarely, as you know, Joel, counteract such serious drug-drug interactions.
Right. So sometimes maybe in our like advanced progressive patients, we might have to, we always used to use your help, Maya, and like checking for polypharmacy for our very progressive patients who maybe have also comorbidities when they have lots of drugs, and we have to check if some drugs interact. So in that case, yes, maybe. So we have other questions like, so someone's asking if there are vitamins that can be especially helpful for MS patients.
So there were a lot of studies studying, for example, omega-3 in MS, vitamin B12 in MS, but all they were negative studies. So the only link was found between vitamin D deficiency, and I think Gina will talk about vitamin D deficiency as one of the risk factor for multiple sclerosis. So vitamin D deficiency might be one of the risk factor for developing MS, and actually vitamin D deficiency was linked to progression of the disease, and that's why it's better to supplement, to check vitamin D level on our MS patient and supplement them with vitamin D supplement. So this was the only vitamin that showed link between MS and its deficiency.
Okay, thank you. And for people who are asking about like the presentations later on, they will be probably put in the IVPN library, as I know, right?
Yeah.
So are there other anti-CD20 drugs in the pipeline or under investigation? And do you see anti-CD20 as a potential drug target for future drugs?
Yeah, of course. So we already have two drugs that are FDA approved and EMA approved as anti-CD20. From our experience, they are very effective and they are very well tolerated. And really, the patient, they are very satisfied with those treatments, and we can see their high efficacy in controlling the disease with very, very well tolerated safety profile. And we have one of this IV medication that's recently approved now in the pipeline. Most of the research focus on BTK inhibitor, which is a new target in MS management.
Exactly, the new era, maybe.
New era, yes.
With a new future. Okay, so I think we will move to our next talk. So I'd like to welcome Gina back. Gina, are you with us?
Yeah, I'm here. Can you hear me?
Perfect. Yes, we can hear
Perfect.
you.
Sorry for the technical difficulties.
No problem, no problem. So I
Always.
introduced you in details earlier, but I'll give a brief again. So as I said, Gina is the clinical nurse coordinator at Cleveland Clinic Abu Dhabi, and her talk will focus on epidemiology and pathogenesis of MS. So thank you, Gina, for being with us. So in the benefit of time, we'll start immediately with Gina's talk.
Thank you. Thank you for that introduction, and thank you for inviting me here today to talk tonight. As Joelle was saying, tonight my topic of webinar will be the epidemiology and pathogenesis of MS. Next slide. So as per the World MS Atlas, 2.8 million people in the world are living with MS, and that's up from 2.3 million people. And 1 in 3,000 people in the world are currently living with MS. And every 5 minutes, someone in the world is also diagnosed with MS. Next slide. So the reasons for the possible increases in the prevalence for the MS diagnosis is possibility of the improvement in MS diagnosis. There could be an improvement in the MS treatment and support, and also the improved ability to count the numbers of people with MS. So currently, with increased registries for MS patients, we're able to more accurately count the number of patients that are diagnosed with MS than we previously have been before. Next slide. So in regards to epidemiology, we all know that it's a study of disease in people. It looks at patterns, causes, and effects of health and disease conditions in defined populations. And the epidemiological studies help to identify factors that might be related to the risk of developing MS, such as latitude, migration patterns, genetics, and infectious processes, which I'll be discussing in more detail in my later slides. It is important for us to just study the epidemiology of MS so that we can, in hopes, develop a cure in the future for MS, which is what all of our MS patients hope for in the future. Next slide. So in regards to the latitude, it's been found that if you do live at higher latitudes, it is associated with a younger age of MS onset. And the age of onset was actually on average 2 years earlier among those individuals that do live at higher latitude regions than those living at lower latitude regions. The latitude gradient often refers to the fact that the people living at higher latitudes are more likely to develop MS. So that means if you're in the Northern Hemisphere, it's those people that are living closer to the North Pole, you're more likely to develop MS. And also in the Southern Hemisphere, you're also more likely to develop MS as well. Areas that are furthest from the equator do have the highest prevalence of MS, and conversely, MS is rare in populations that live near the equator. Next slide. Yeah. So, however, scientists have found that if you do move from one geographical area that is of low risk of MS to an area that is high risk before you hit the age of puberty, it actually increases the person's risk of developing MS. Conversely, though, if you do move from an area of high risk to area of low risk before puberty, you can decrease your risk of developing MS. This is basically showing that the environmental factors also contribute to risk of MS that come on early in your life. Next slide. So the etiology and pathogenesis of MS does remain unclear. But the cause of MS is also multifactorial, and we'll be discussing the genetic predisposition of MS, the environmental factors such as infectious agents, vitamin D deficiencies, and smoking. Next slide. So we all know that MS is not an inherited disease. It's not passed down from generation to generation, but people can inherit the genetic risk of having MS. Next slide. Currently, the MS Atlas shows that there's at least twice as many females with MS as there are males, 69% of females versus 31% of males. And in the Western Pacific region, 78% of the individuals are female. Southeast Asia, 76%, America, 71%, Europe, 69%, Africa, 67%, and the Eastern Mediterranean, the 66%. So this shows that, as we all know, females are more prevalent to have MS than males. Next slide, please. So the risk among first-degree relatives to have MS is 10 to 50 times higher than the general population. So it's generally about 2 to 5% risk. And the monozygotic twins is about 1 in 3. So generally all of our MS patients worry about passing down MS to their children. And we always tell them that it's a very small percentage, that just because you have MS doesn't mean that you will pass down MS to your children. Next slide. So in regards to genetic predisposition, there's the human leukocyte antigen complex that contains multiple genes related to the immune system functioning, and the HLA genotype has been increasingly well characterized regarding MS risk. This is basically showing that even with the genes, you could have an increased or decreased risk of MS, but it doesn't exactly correlate to you having MS just because you have the genetic risk for MS. Next slide. So there are other factors that involve, so it's not, as we know, it's not handed down from genes, but it could be a combination of all factors. So genetic environmental interactions that may contribute to MS pathogenesis includes vitamin D levels, obesity in childhood, EBV infection, and smoking. So even though the MS risk is higher in patients with first-degree relatives, it doesn't mean that they're definitely going to be getting it as well. Some people that have MS may not even ever pass down the disease to their children. However, with that being said, even though we know that there's a potentiality for genetic risk for MS, there's currently no genetic testing that is recommended for at-risk individuals, because again, like I said, some remain MS-free, even though they are genetic carriers. So in clinical practice, we don't actually test for genetic variants for MS patients that are at risk, even because again, there's no potentiality for you having the gene and then definitely having it. Next slide. Moving on to the environmental factors for the infectious agents. They were first suspected to be the etiology of MS soon after the classification as a discrete clinical entity in the late 1800s. We know that MS is the most prevalent chronic inflammatory and neurodegenerative disease of the CNS system, and predisposed by an infection agent mostly commonly known as EBV as the lead candidate. So there are a growing number of researches that currently indicate that previous infection with EBV contributes to the risk of developing MS. And as we know, EBV is a common virus in teenagers and young adults. It's also been proposed as a possible trigger for MS and is also implicated in some cancers. Next slide. Although 95% of the population is exposed to, the previous one, sorry. Yeah, so even though 95% of the population does have EBV or have been exposed to it before, not everyone would have EBV and translate to MS. So the risk of developing MS is approximately 15-fold higher among individuals with a history of EBV in childhood and 30 times higher than those infected with EBV in adolescence or later in life. Next slide. So again, like I said, having EBV doesn't mean that you'll get MS. But if we detect it early on, we can see that practically everyone with MS that previously had EBV infection has MS. So there have been studies that shown that everyone that has MS has EBV. So there's a current US study that tracked people who gave blood samples over several years, and they can see who has actually been infected with EBV. They show that the risk of developing EBV was actually, MS was actually much higher after they were infected by EBV than shown. Next slide. So the US study actually took samples from 801 people who developed MS, and they actually compared that to samples of 1,500 people with similar characteristics that didn't develop MS. And this team found that there was a much higher rate of EBV infection among those that developed MS than the control group. So out of 801 MS cases, like I was saying, only one person tested negative for EBV in the sample collected. So this is showing that the people infected with EBV were 32 times as likely to develop MS as uninfected people. Next slide. So basically, this study was showing that the association between EBV and MS risk was much too strong to be explained by any other known MS risk factors. However, the findings strongly suggest that EBV is part of the chain of events that leads to MS, but EBV in itself isn't the only factor to trigger MS, but there's other factors that play a role in it as well. Next slide. With that being said, what people want to know is why don't we just vaccinate for EBV and do that? There are currently clinical trials ongoing that are looking for vaccines for the EBV virus. And these trials are, however, still in the very early stages, and they are targeting different cell types involved in the immune system. So, however, once the EBV vaccine does eventually become available, this could help reduce EBV infections, and in return, hopefully less people will go on to develop MS. Next slide. There is currently a research study going on from the National Institute of Allergy and Infectious Diseases through the National Institute of Health. They are currently in a phase 1 study out of Maryland to study the safety and efficacy of an EBV vaccine. So hopefully with this study ongoing, we can roll out an EBV vaccine. Next slide. The current enrollment of this phase 1 trial are 40 healthy volunteers between the ages of 18 and 29. Half the participants will have had an EBV infection in the past, and the other half will have not. Participation will be for 18 to 30 months, and the trial is expected to last for 4 years. Next slide. So as someone was asking a question before in regards to vitamin D and MS, we do know that vitamin D is strongly linked to MS in terms of worsening the relapses, symptoms, and getting MS. So vitamin D supplementation helps to reduce the relapse rates in patients with relapsing remaining MS. There's a current study where with 134 patients who were able to complete the study. 43 of them were vitamin D insufficient or were deficient at baseline. And in these individuals, with each millimole increase in serum vitamin D that was achieved as a result of supplementing with vitamin D oral tablets, capsules, they were associated with a 0.014 reduction in annualized relapse rate. Next slide. Next slide. So these findings support that to supplement with vitamin D supplementation. So even though you're vitamin D deficient, diet alone and sunlight exposure is not enough. And most oftentimes we find that our patients do need vitamin D supplements. We do check our patients at baseline and then provide vitamin D supplements, and then check on a yearly basis to ensure that they are within normal levels. And there's currently research studies ongoing to help establish the relationship between sunlight, vitamin D and MS, and vitamin D supplementation and narrowband UVB phototherapy for the prevention and treatment of MS. Next slide. So what is important to know that studies have been shown to prove that vitamin D is helpful if you already have MS in many ways. Optimal vitamin D levels shows an increased, an increased level of vitamin D is associated with a decrease of a risk of relapse. And if you already have a DMT that you're already taking for MS, it also helps to reduce the risk of relapse. And higher levels of vitamin D are associated with fewer new MS brain lesions and less severe brain shrinkage. In terms of optic neuritis as your first demyelination attack, but have not converted to MS yet, vitamin D will also help to delay a second clinical attack. Next slide. So how exactly does vitamin D protect the nervous system? Vitamin D may provide a protection by reducing free radicals and inhibiting related molecules. And also vitamin D protects the nerve layer in the retina from thinning if you have optic neuritis. Next slide. In regards to environmental factors of smoking for the MS, studies reveal that there's a marked association between smoking and MS. Environmental factors like smoking are risk factors for the development, severity, progression, disability, and early death in MS. It's a major environmental risk factor for the incidence of MS, and it plays a vital role in immunological mechanisms. Next slide. So there's currently data from multiple studies right now that show, or in general, that tissue injury in MS is due to an abnormal immune response to one or more myelin antigens that develop in genetically susceptible individuals after they're exposed to cigarette smoke. Therefore, if you stop smoking, it could help alleviate atypical immune responses and tissue damage. Next slide. So tobacco contains high amounts of free radicals. It has been reported that free radical-induced oxidative stress can actually cause mutations in genetic material and is involved in several neurodegenerative disorders such as MS. And the tobacco increases the risk of autoimmune diseases like MS. Next slide. Smoking acts on the cellular level of the immune system, resulting in the development of pro-inflammatory cytokines. And smokers have higher levels of pro-inflammatory cytokines. Smoking decreases the number of peripheral B cells and natural killer cells, and decreases the production of cytokines by antigen-presenting cells, and reduces blood levels of serum immunoglobulins. Next slide. There have been a few studies that have been ongoing in regards to smoking and MS. There was a current study that examined 3,052 cases against 4,557, 619 controls. And this reported a relative risk of 1.48 and concluded that smoking actually might increase the susceptibility to MS. Another study showed that past smokers and current smokers had significant risk of developing MS. And another study showed that over a 6-year duration of the disease, compared never smokers to ever smokers, so people that have ever smoked, were more likely to have a progressive illness. Next slide. So how exactly does smoking affect the progression in MS? At first diagnosis of MS, 67% of smokers can go on to full clinical defined MS, compared to 35% of non-smokers. And smoking increases the relapse rate in people with RRMS and also increases the risk of disease progression. So smokers are both more likely to get an advanced EDSS milestone and more likely to get there sooner than their counterparts that don't smoke. Smoking also increases the speed and risk of progression to SPMS. Smokers with RRMS got to the secondary stage of MS approximately 4 years earlier than non-smokers. So every additional year of smoking after diagnosis of RRMS accelerated the time to SPMS by 4.7%. Next slide. So how does smoking affect people with MS? lowering the quality of life, increases MS activity on the MRI scans as well as clinically, and provides greater disability. Next slide. In a current study out of the UK, there were 7,983 participants, basically showing those that have ever smoked, were current smokers or formerly smokers. This study showed that those that were smoking had a higher disability compared to those who never smoked. Next slide. And so the role of basically this is quit smoking. So we always educate our patients at the start of our MS sessions with our patients that if they do smoke, it's time to quit smoking. Because every smoke-free year decreases your risk of progression to a greater level of disability. And ex-smokers actually have the same risk of progression in MS as non-smokers. So basically, after you stop smoking, the changes to your cell DNA steadily reduce. After 5 years, you would basically look like a person who has never smoked. So cutting down on the amount that you smoke also helps to reduce the damage. We tell our patients that we understand that smoking is hard, so we try to support them in any way that we can. And this includes encouragement throughout the whole MS disease progression, and also providing support through smoking cessation programs, psychologists if they need to, but just being there for them to let them know that just because you do smoke, you can still quit smoking and it will still help you and your MS. Next slide. We know that smoking was associated with brain atrophy and disability progression 10 years later in patients with RRMS. And when smokers do quit, there was a slowing in the rate of motor disability deterioration, so that matches the rate of motor decline in those who have never smoked. Next slide. So after 10 years of smoking, individuals with MS showed lower total white matter volume and higher T2 lesion volume. It was associated with lower deep gray matter volume, and also there was a higher walking impairment on the 25 time-foot walk test and a larger decrease in the PACE auditory serial addition test scores. Next slide. So patients often think that if I'm on a disease-modifying treatment, that it'll protect me from all external factors, and that's not true. The DMT actually doesn't protect you from the risk of smoking. So it's actually not been shown to reduce the risk of smoking in people with MS. And a Danish study was actually showing 834 patients with RRMS that was on beta interferon treatment, and found that 27% more relapses among smokers than non-smoking, irrespective of their underlying genetic susceptibility. So basically, this implies that smoking makes the DMT less effective at protecting you from relapses. Next slide. So as I stated previously, smoking cessation is beneficial for people with multiple sclerosis. Patients should be advised and offer aid in smoking cessation shortly after diagnosis to prevent long-term disability progression. Next slide. So overall, in terms of MS risk factors, the recommendations for individuals at risk for MS are consistent for those general health benefits that may help to reduce the risk of MS. And those include, as we discussed, smoking. So avoiding the exposure to first and secondhand cigarette smoke, increasing your sun exposure and vitamin D supplements when needed, and also preventing childhood obesity. And next slide, that should be. So in summary, increased prevalence in MS numbers could be a result of improved diagnosis. Continued studying of the epidemiology of MS is important for the possibility for cure of the disease. Ongoing research in the role of EBV and MS could help to reduce EBV infections, thereby reducing the number of people to go on to develop MS. Increased levels of vitamin D will help to reduce relapses, lesions, and brain shrinkage. And smoking is a risk factor for the development, severity, progression, disability, and early death in MS. And thank you all for joining in my talk today. That is the end of my talk.
Thank you. Thank you so much, Gina, for a very informative talk. It's very important to talk about the increasing prevalence in our region, because it's a true increase of prevalence, definitely. Our patients do deal, the numbers from our region do show that our patients deal with with actually more severe disease. The numbers from our region, as not just are increasing, but it actually does show that patients in our region also deal with more aggressive disease. You've also shown and talked to us about the important risk factors, and you've also mentioned one of the most important findings of this period, which is the EBV and the risk factor of EBV. Now let's see some of our questions from our audience. So someone's asking if there's a relationship between MS and other diseases such as Alzheimer's, Parkinson's, and arthritis.
Sorry, could you repeat the question?
They're asking if there's a relationship between MS and other diseases such as Alzheimer's and Parkinson's and arthritis. I'm
assuming they mean, if you have MS, is there a risk to develop Alzheimer's later on or Parkinson's and that sort of thing? I would say no, but maybe they're more saying that with the cognitive decline shown in MS patients later in life, maybe they're associating that because, again, like we know, patients with RMS with the transition to secondary progressive MS, that does unfortunately include cognitive decline, increased fatigue, increased other weaknesses, that's just the natural course of the MS progression. And however, hopefully with new and great medications that we currently have available, like Simpton or ocrelizumab, that will help slow the progression and maybe deter them from not even being how patients are 15 years ago that didn't have any medications.
Exactly. So with high efficacy therapy, that's the point. But with the diseases that the question mentioned, not really. There hasn't been shown increased comorbidities. There is like increased comorbidities with other autoimmune diseases and MS, but not specifically with the diseases the question mentioned. They're asking about supplements, like what supplements can be taken alongside MS. So
that's a huge question that every one of our patients ask time and time again. So for some reason, B12, omega, those have been the hot topics of patients wanting to take natural supplements, all of that. We don't tell them not to take it, but we're clear that there's no actual link between taking B12, herbal supplements that will help improve or deter the MS. Like Maya was saying, vitamin D and MS are strongly linked. So we encourage you to, at least if you're going to take any supplement, take vitamin D.
Yes. So we always like to give our patients what is really led by evidence, but other things can be under the complementary and the alternative medicine.
Exactly.
But, if there's no strong evidence, then.
Exactly. We say whatever makes you feel better in your care plan, that would be beneficial. Yeah.
Definitely. Okay. So there aren't any more questions. Okay. So thank you so much, Gina. Thank you.
Thank you for having me. Thank you everyone for attending tonight.
So we're going to move on to our next talk with Dr. Yolanda. So Dr. Yolanda is an assistant professor and a nurse researcher at the University of Alabama at the Birmingham School of Nursing. So in addition to her duties as a professor at the nursing school and her various research endeavors with the U.S. network of pediatric MS centers, she's also a nurse practitioner at the UAB's Center for Pediatric Onset Demyelinating Disease for nearly 17 years, where she cares for children and their families with multiple sclerosis and other demyelinating diseases like MS. She's also been a longtime volunteer and a patient advocate. She has done work with organizations like the National MS Society in the USA and the Multiple Sclerosis Association of America and Can Do MS. All of that to ensure that patients and their families receive quality and equitable care. We were very happy that she agreed to join us today for our webinar. And we want to go into a very special topic and a rare entity in MS, which is pediatric MS, to talk about what's new in pediatric MS. So thank you, Dr. Yolanda, for joining us. And I will leave the floor to you. You can share your screen. And we apologize a little bit for the delay in the program.
Okay, can everyone see my screen?
Not yet.
Okay.
No worries, take your time. Yes.
How about now? Okay. So thank you so much for this opportunity. This is a long passion of mine, so I am excited to be here. I have two screens, so if it looks like I'm not looking directly at you, it's because I'm looking at my other screen to direct my conversation. Here are my learning objectives. I have no disclosures that are relevant to this presentation. And I want to talk a little bit about pediatric MS, and there's so many different aspects that I could talk about regarding this topic, but I want to talk about pediatric MS as it relates to treatment options and clinical trials, and the challenges that we've had with medication regarding pediatric MS. So I think Dr. Amaya, I'm not going to butcher her name, I'm just going to say Dr. Amaya spoke about treatment options in the adult and the treatment options for acute onset or acute demyelination is very similar to that is utilized in pediatrics. We use high dose steroids, whether they be oral or intravenous. 17 years ago, most certainly, we used only IV, and then there were studies that came out that showed that high dose oral steroids are just as effective as intravenous. We use intravenous immunoglobulins if we see that the patient may not be responding to steroids well. And then even if they're not doing well after IV immunoglobulins or steroids, high dose steroids, we may even move on to plasma exchange. And then you have those things like symptom management that are utilized to ensure that the patient is not having any lingering symptoms that need to be treated, and as well as physical therapy, occupational therapy, speech therapy, and cognitive behavioral therapy. And the goal for acute treatment, as Dr. Amaya mentioned, was just to get them back to their optimal health in the least amount of time as possible. As you know, 99% of the patients, pediatric onset multiple sclerosis patients, have relapsed and remitting disease. So that's what guides most of our care, getting them back to their optimal level of health at the quickest amount of time. But the goal of long-term treatment, and I like this visual, is to try to get them where they have no relapses, where they're not having any active T2 lesions, no GAD-enhancing lesions, and that they are not progressing toward disability by evidence that they have the capability of walking and not using any assisted devices. So this slide is a very popular slide because I've seen it earlier tonight in our session, but this is a visual of all the disease-modifying therapies. 17 years ago when I started, there were 4 disease-modifying therapies that were all injectable. And then we had this takeoff of drugs being discovered and invented for multiple sclerosis. You will see that this was from 2018, and the ones that have been added since 2018 are outside in this outer box. But you'll see that there are 25 plus drugs, whether they be name brand or generic, that are related to disease modifying therapies used in the treatment of multiple sclerosis. In the red, you'll see some boxes encapsulated. And these are, although we have all these drugs, they're not FDA or EMA approved for pediatrics, and we'll talk about that a little later. So injectables in POMS, of course, are the interferons and glutaminyl acetate. In 2012, the International Pediatric MS Study Group set guidelines that recommended early treatment with either glutaminyl acetate or interferon beta. Although, again, these drugs have been utilized almost 3 decades now, they are not approved by the FDA or EMA for the use of in the treatment of pediatric onset MS. Data in POMS was all retrospective, and there were open label studies that were conducted. They did show a decrease in annualized relapse rate from pre-treatment, and treatment failure with injectables was cited at 25 to 65%. And so these were the drugs that we used. Being a clinician from 17 years, there was a fight to get these drugs approved because they were not approved by the government. Injectable DMTs and POMs overall were deemed as safe and effective. They did see that there were elevated LFTs more common in kids. Then there was the issue of localized site infections, necrosis, and lipoatrophy, because patients oftentimes, if they were doing injectables, especially if it was most of our patients are teenagers, they don't want to rotate injection sites. And so they would use the same injection site, and they were more at risk for lipoatrophy. And so there was an issue with body image. Then for those individuals, those young adults or adolescents who had depression, they were more at risk for depression because of the use of these injectables, particularly those adolescents who had a predisposition to depression or anxiety or some other mood disorder. But again, like I said, despite the fact that these drugs have been used for decades as first-line therapy in pediatrics, they still remain unapproved. Then we had the era of the oral DMTs and POMs. We had fingolimod, which was the first approved agent, and we'll talk about that in the clinical trial related to fingolimod in peds in just a moment. But it was the first oral agent that came out most recently this year, in February of 2023. The disintegrating tablet that is the generic or same mechanism as Gilenya came out, and it's offered in 2 different dosings for patients with pediatric onset MS. And then we have teriflunomide as well as dimethyl fumarate that are all oral agents that are used in pediatrics. And actually, teriflunomide is not used more so in the USA, but it's used in Europe and other places. So the first study that I want to go over is the PARADIGM study. The PARADIGM study was a phase 3 randomized, double-blinded, active control parallel group clinical trial that was conducted started in 2013 and still ongoing. It compared fingolimod, the oral tablet, to IM interferon beta 1A in 108 children between the ages of 10 and 17, and they did this study up to 24 months. The mean age was 15, with the mean average rate of relapse at 2.4 in the past 2 years. The primary endpoint was an annualized relapse rate, and then the secondary endpoint was an annualized rate of new or newly enlarged T2 lesions, whether they be non-enhancing or enhancing. And so in 2018, finally, after this study was completed, or the preliminary data, it was approved by the FDA, fingolimod, and as well as the EMA for MS in children greater than 10 years of age. Currently, like I said, this is the only FDA-approved medication for POMS. And this is just a graph that shows how, from the PARADIGM study, that fingolimod reduced the adjusted annualized relapse rate from 0.12 to versus that of interferon beta from 0.67. And so there was a reduction in the annualized relapse rate of non-enhancing lesions from 4.39 versus 9.37 for beta interferon 1A. It reduced GAD enhancing lesions and new T1 enhancing lesions, as well as the rate of brain atrophy. And it also reduced the risk of confirmed disability progression. Here is just a slide demonstrating the different adverse events that happened during the paradigm study, mostly common as the other adverse events that were cited in the adult when they did adult studies for these particular drug classes. And so it's not very different from what you see in the adult studies that were being conducted. Then the next study is the TerraKid study. It was a phase 3 randomized double-blinded trial that was conducted from 2014 to 2021, and it compared teriflunomide to a placebo. And 109 pediatric patients between the ages of 10 and 17 for up to 24 months. The primary endpoint was the time to first relapse. Secondary endpoint was the number of T2 lesions, non-enhancing and enhancing, and the number of and the patients with confirmed relapse or high MRI activity during the double-blinded study period could actually switch to the open label if they had a relapse during the trial. Here's just some more visuals of the data that was obtained from this study. The prolonged time to first relapse was 75.3 weeks versus 39.1 that was seen in the placebo group. The reduction in T2 lesions was by 55%, and the reduction in enhanced lesions was 75%. Teriflunomide, there were some adverse events that were cited, and those patients that switched to the open label extension due to high MRI activity, because there was no primary endpoint gathered, this drug was never approved by the FDA for the treatment of POMS, but it was further approved by EMA for POMS for those children between the ages of 10 and 17. Then we have the CONNECT study, which was a phase 3 randomized active control open label trial that was conducted between 2014 and 2025, so it's still ongoing. They've gotten the preliminary data and they're finishing up the data. It compared dimethyl fumarate in 78 individuals to those that were on interferon beta 1A in 72 patients that were between the ages of 10 and 17 for 96 weeks. So they're finishing up this clinical trial. They have gathered all the participants who would like to be in this trial, but they're not collecting any new, they're just finishing up the data. The primary endpoint was the number of patients free of non-enhancing and enhancing T2 lesions, and the secondary endpoint was the number of non-enhancing and enhancing T2 lesions and the number of patients free of relapse, annualized relapse rate, and they were also looking at safety of the drug. Comparison for the versus non-enhancing lesions was 16.1%. More patients had those less amount of lesions versus that group of beta interferon users that had 14.9%. So you can tell the difference. There were more relapse-free patients at 96 weeks, and there was a lower adjusted annual relapse rate. In kids, they have more relapses in the first 2 years when their disease is more active. And so these studies are very promising in the pediatric group. Then we have the infusions in POMS, and there have been a lot of retrospective studies where clinicians have used these medications and they have reported on the findings based on their specific clinics or their specific areas where they're treating patients. So I did not, for the sake of time, did not report on all of these retrospective studies that may have not had a lot of or yielded a lot of patient data. For the infusions in POMS, there's natalizumab that's being used, alemtuzumab, ocrelizumab, and rituximab, and we'll talk about these briefly. So natalizumab in POMS, again, these this data is basically based from retrospective studies of individual centers or individual providers who have done or been utilizing these meds, because they are not, again, FDA or approved. And so I'll just highlight that the biggest study was in 101 patients who had highly active MS. So that means that they were on some DMT previously, but their MS was highly active. The mean age was 14.7. The mean treatment was 34.2 months. The mean EDSS went down from 2.6 to 1.3. Annualized relapse rate went down. And as a follow-up, 58% achieved NETA, and no relevant AEs were cited. So from this study, from the studies that were shown, natalizumab appeared to be very highly efficacious and well tolerated in POM. Then we have LimKit. It's a study that was started in 2017. It is still ongoing. Preliminary data was released in 2022. This study was discontinued prematurely in 2021 due to safety concerns. It was supposed to go on till 2025, I'm sorry, but it was discontinued due to safety concerns, and they were not specific when they reported this information, what safety concerns they had. It was a phase 3 open label trial, single arm, before and after switch study in patients between the ages of 10 and 17 who failed at least 2 DMTs. This study was very small. It only enrolled 16 patients. The mean age was 14.5. 11 had completed treatment for over 8 months. It did show some decrease in the amount of new and non-enhancing lesions, and with those patients that were in the study. Then we have Operator 1, which is a phase 2 study, open label clinical trial. Preliminary data, it was available in 2022. It was a dose finding study, and it looked at PK and PD, if the efficacy and safety results. Exploratory endpoints included relapses, MRI activity, T2 lesions, as well as non-enhancing lesions. And this is more data that was shown from Operator, looking at ocrelizumab and looking at the T2 lesions at baseline and how they were reduced by week 12. If you can see, there were no new GAD-enhancing lesions by week 12, which is very promising in the pediatric cohort. And then, as you can see, the T2 lesions were also reduced by week 24 to 0 in both cohorts of these patients that were participating in this study. And as of October 22, no patients that were enrolled in these studies, and again, these are very small studies, no patients had relapses at October 2022. Then you have Operator 2, which is an ongoing phase 3 randomized, double-blinded, double-dummy clinical trial comparing ocrelizumab to fingolimod in children between the ages of 10 and 17 years of age. And they're going to be looked up to 96 weeks. Cohort 1, and I didn't go over that at the slide before, but cohort 1 was those children who had a body weight less than 40 kilos. And then cohort 2 were those children that had a body weight greater than 40 kilos. The primary relapse was annualized relapse rate. And the secondary endpoint, again, is T2 lesions, number of enhanced lesions, AEs and ADAs. With that being said, that study is still ongoing. They have not published any data for this, but ocrelizumab is looking very promising in the pediatric group as well. Then you have rituximab, which is an older drug. It is a B-cell depleter that has been used in rheumatology and other disciplines in the pediatric world for probably 5 decades. and it's been looked at in adults with MS, but has not ever been approved in adults in MS, but is still being utilized. There have been large studies that have been published and completed with regard to relapsed and remitting multiple sclerosis, and they just demonstrated safety and efficacy with the use of this drug. There have been some retrospective studies in PALMs that have looked at this medication as well, and it has showed promise for lowering relapse rate, making the EDSS stable, having non-reduction in T2 lesions and enhancing lesions, and has also caused some promise with the treatment of relapsed and remitting MS when it comes to PALM. There were very few serious risks. Most of them were related to viral illnesses that were unique to the pediatric population, but none had an increased risk in invasive cancers. Infusion reactions were usually mild to moderate, primarily with that first infusion. And then you have that diminished vaccine response is very unique to pediatrics, especially because most of them are still at the age where they are receiving vaccines or on a vaccine schedule. Current evidence supports effective use of rituximab and PALM. Anti-B cell therapy requires long monitoring, though, and may pose a risk to hypergammaglobulinemia, malignancies, infection, and vaccine response. This drug is utilized primarily in the United States because it is a relatively affordable drug, not just in the United States, but in many regions in comparison to the other MS DMTs that we're utilizing. And there needs to be a consensus on dosing, treatment duration, and lab monitoring when it comes to this drug, because that has not been established. So medications that we typically use in pediatric MS are the interferons and then glutathione acetate, brand and generic. We have used less of that because what we have found in the US is that a lot of the patients were having breakthrough disease on these meds. A lot of them were having a lot of relapses at the beginning. And so when the newer, more efficacious drugs came out, we were making switches to those drugs. Natalizumab is being used, teriflunomide is being used, dimethylfumarate is being used as well, brand name and generic. Ocrelizumab is being utilized as well, although it's not FDA or EMA approved. Ofatumumab, I will bring that to your attention, is being used. I have two patients actually in my own unique clinic that are utilizing this drug. Dr. Mize talked about this and how it is fully humanized. And we had two patients that were receiving rituximab who had anaphylactic reaction. And under the monitoring of pulmonary and immunology, they were able to successfully start ofatumumab and not have any side effects or not have any anaphylactic reactions to this drug, and are still on this drug after a couple of years. Lemtrada has been utilized in United States as well as again, rituximab is often used for those patients who have Medicaid, who are on a government-assisted insurance program, as well as fingolimod. Treatment choices are very dependent upon the comfort level of the treating clinician. Presenting MRI, they have, again, high disease or a high burden of disease on MRI. They may not just start off on a first-line therapy, but a second-line therapy. And then the level of disability, as well as patient preference and or lifestyle, as well as insurance and what the insurance will approve. Challenge in pediatric MS clinical trials. There has been a lot of challenges that we have identified. The one challenge that sticks out to me that probably kind of dictates participants, we have a small yield of patients, but there are also ethical concerns about studies that include the use of placebos, especially in the face of highly active disease. And that kind of drives our choices about incorporating pediatric patients in MS clinical trials. Other things include time to complete enrollment due to limited number of candidates, limited trial experience by enrolling sites, because they're not used to enrolling patients in clinical trials that require a fine level of detail, low rates of consent from eligible participants due to site design, travel, and burden of visit frequency, risk of incomplete enrollment, financial risk, as well as site-specific challenges that clinicians may encounter when they're trying to enroll a patient in a pediatric MS clinical trial. Treatment challenges include that shared decision-making. Not only are you thinking about the treatment that's best for your patient, but the treatment that's best for their caregiver, whether that be a parent, grandparent, or whomever is caring for that child. It has to be a decision that has to be made not only by that patient, what the patient is willing to do based on their age, but also that caregiver as well as the treating provider. Then adherence issues. You want them to be on a medication that they're going to stay on. If I have a younger patient that has pediatric MS, I often tell the parent, it may not be your decision about what's convenient for you. It may be an inherent issue. I've often had patients who were on an oral drug that the parents thought that they were taking. They did not really monitor that child and found out after having a relapse that they were not adherent to the medication. Then you also have to consider insurance approval, especially in the face when those medications have not been approved, or you can't get easy access to that drug because it is not approved by their insurance and you have to do prior authorization. In summary, children with MS may have frequent and severe relapses, high lesion burden, high risk of long-term physical and cognitive disability. There's an issue of adherence, efficacy, and drug access that affects that DMT choice. The high efficacious DMTs improve disease course, but risk must be carefully weighed in children. More clinical trials and long-term safety data is needed in high efficacy DMTs, and early and effective treatment in children is paramount. And that's my takeaway for this presentation.
Thank you so much, Dr. Yolanda. So we always know, like, the topic of pediatric MS is probably difficult to talk about a little bit, and also to summarize, because there's always very little data because of the fact that it's rare. But you know, we did a beautiful job of summarizing where we are so far. So we do have a question, some of the questions that are coming up. So a general question that might be difficult to answer because it's not very specific, but someone's asking about, like, the dosing regimen of some of the medicines you asked in pediatrics. So maybe what they mean is are there changes when we talk about dosing medications in relation to pediatrics versus adult dosing? So maybe we can talk about the approved ones, let's say.
That's a great question. So most of the pediatric population, although they're younger, they are adult in size, if yes. I should, yes, they are adult in size. Most of the occurrence of pediatric MS occurs between the age of 14 and 17. And most of those individuals are adult in size. And so there does not have to be alteration in the dosing. I know most certainly 17 years ago when I started with the injectables, we kind of developed our own little regimen. There was no guidelines, and we had to decide, you know, we're going to do a half dose, and and we oftentimes would move patients up and make up guidelines for dosing.
Titration.
Yes, especially with the interferons,
Right.
because the other meds don't have a lot of side effects. Of
Right.
course, with rituximab, you know, you dose it based on 750 milligrams per meter squared. And so you use that as your guidelines. But all the other meds, we have just really, because the kids are mostly adults in size, we don't have to do a lot of alterations. Those younger kids, where it happens, where it is during an age where they're younger than, I say, 14, a 10-year-old, we base it on weight, and we oftentimes refer to our pharmacies and our adult colleagues about their recommendations. But for the most part, that's a rare instance these days, because most of the children, even we have younger kids who are much younger, who may just be adult in size, as far as BSI.
Or like the
BSA
orals,
is concerned.
let's say, for fingolimod, there's no dose adjustment, right?
Right, right.
So do you use do you use rituximab frequently?
Yes, so that is, I will be honest with you and say, in my clinical practice, a lot of the patients are have low income, and so they are on Medicaid, and we use a
Yes.
lot of rituximab.
Yes. So and Maya would agree with me, because we also used to practice in Lebanon before I moved to the UAE. So we also used to have a large refugee population as well. So we have a huge experience with using rituximab as well for people
Mhm.
from low socioeconomic backgrounds, because it's much cheaper, and it used to, and we have published as well on that. Maya can also vouch for that. So we've used that a lot. But do you use B cells, measuring B cells for extending dosages and dosage
Yes,
intervals for rituximab?
So yes, we do utilize, we monitor lymphocyte markers whenever, and I will say, for the African American patients, that I have a clinic that has a high incidence of African Americans in my clinic, and they're repopulating B cells earlier, and they were having breakthrough disease.
Okay.
And so instead of them getting their infusions every 6 months, some of them are on 3 months, some of them are on 5 months, some of them are on 4 months, based on how they're repopulating their B cells.
That's after giving how much dosage of what?
We're giving 750 meters per square. Yep.
Okay.
1,000, they're getting 1,000 milligrams.
Wow. Okay. That's quite a different experience, because I mean, here definitely we have a lot of like expats and people of different racial backgrounds, so we should definitely keep that into account, and measuring, looking at B cells from from a different perspective based on that. So thank you for that input. Yeah.
Yes.
Okay. Is it, I wanted to ask something as well. Is it more difficult to achieve NIDA in children, and like to look at no evidence of disease activity from a different, at different aspects of NIDA in children, and to monitor that? Is it more difficult?
I don't think it's difficult to monitor. We've just gotten into the use of the drugs that I think would actually help us achieve NIDA.
Yes.
That's what I feel like. And what we're seeing now, which is a little different, we're seeing a lot of opportunistic infections with the B cell therapy. They're getting a lot of sinusitis, a lot of we've had some, hospitalizations related to infection, and I think they're related to their B cells being depleted.
Okay.
And so we don't know yet, because we can't tell what the correlation is, but we're having, so we're doing surveillance with these particulars, and these particular patients we've looked at are not getting it any more frequently than every 6 months. So
Yes.
And we're checking their immunoglobulin levels,
Yes.
and they're no lower than anyone
wanted to
else.
ask. Yeah.
Right. They're not any lower than anyone else. So
Interesting. Okay. All right. Maya, do you have any questions for Dr. Yolanda, Gina, anyone? Okay. So I guess
It was a very good and interesting talk. It was good to
Yeah.
listen to that. Yeah.
Yeah,
it was
excellent.
really enriching. Thank you.
A very comprehensive talk about pediatric MS.
Yes, we were glad to hear from an expert.
Yeah.
Really.
Yeah.
well, thank you.
Thank you so much for being with us.
You're welcome.
Okay.
So now we will move to your lecture, Joel, finally. As we say in Arabic, ختامها مسك. So let me introduce for you very quickly, Joel, but I think most of you knows this famous MS, passionate MS nurse. So beside that, she is my dearest friend. Joel is currently the clinical manager of the Neurology Institute and the MS Center at Harley Street Medical Center in Abu Dhabi, UAE. Also, previously, before having this role, Joel was also the nurse in charge at the American University of Beirut MS Center, which was the first multidisciplinary multiple sclerosis center in the MENA region for 10 years. She is also the first nurse and healthcare professional in the Middle East to be double certified as a multiple sclerosis certified nurse and a specialist. She's also an active board member of the International Organization of the Multiple Sclerosis Nurses, representing the Middle East, also on the Multiple Sclerosis Nurses International Certification Board, which was established to develop criteria for certification of and administration of a certification exam for MS nurses. Also, Mrs. Massouh is the nursing program coordinator of the MENACTRIMS, which is our the Society for the Treatment, our Middle East and North Africa Society for Treatment and Research of MS. And every year, Joelle is organizing a nursing session targeting nurses in order to elevate the level of our nurses in the MENA region about MS and prepare more nurses to be certified. In 2019, Joelle, she was awarded the inaugural International MS Nurses Leadership Award by IOMSN at their annual Congress, which is an award that was given for the first time. And just very recently, like 1 week ago, Joelle was also the recipient of the award from the UAE, from another award, which is the let me check. Joelle can help me in this.
So Nightingale Award.
Yeah.
I think
So it is the 90 Gale Award, and Joelle aims through this award to address the gap in communication among the MS community through a mobile app-based support group for people living with multiple sclerosis. So congratulations, Joelle, for this award. And in addition to that, Joelle, she's a lecturer about MS, and she gave lecture for patient, for student, and for the community. And also she's an active researcher. She participates in clinical trial and in observational research, all in the field of multiple sclerosis. So without no further ado, let us all welcome Joelle and listen to her presentation about B-cell depleting therapy for the treatment of multiple sclerosis. The floor is yours, Joelle, and you are always the most welcome.
Thank you so much. So we're gonna end today's webinar by talking about safety and efficacy of B-cell depleting therapies in MS. So these are my disclosures. So we wanted to start by talking about something very, very practical. It really comes from discussions we have as MS nurses with our patients, and only diminishes when patients are really quite advanced. But actually, employment is actually strikingly affected even at lower disability levels. So really delaying progression increases the amount of time our patients are able to work and live independently. So this is a very important point. We have to also note that a proportion of our patients, even at lower disability levels, even at low EDSSs of 0 and 1, concepts like patient-reported outcomes, we have to hear and listen from our patients. There are symptoms that are being, they are facing, like fatigue, like depression, many issues that are affecting how they are dealing with their daily lives. And it's really affecting things like the fact that they are able to continue work, simple daily things they are dealing with that affects in the endpoint, things like employment. So there are unmet needs. Are we compromising things like efficacy and safety? Yes, patients do often have to compromise. They have to think when they are deciding. We said before, the patients sometimes think of it as a linear relationship between their physician and themselves. But no, I always say, and I always, in my lectures, when you attend, we always think about, it's not a linear relationship between the patients and their physicians. The circle is not complete without us as nurses. We can complete that circle. So we always make those decisions as a team, and of course with all the healthcare professionals, with our the team is also complete with other healthcare professionals like our pharmacists as well. And this is how we make those decisions, from treatment decisions to other decisions as well. Sometimes patients believe that they have to compromise. Are they compromising, choosing between higher risk, higher efficacy medications, or between lower risk and low efficacy treatments? Because the thought, or the really like old concepts, and what we used to say is, there are perceived safety concerns with highly efficacious treatments. That's why many patients are started on low efficacy treatments. However, priorities differ. Many of our patients are people living with MS. They are willing to accept the risks in exchange for clinical efficacy. They want higher efficacy, and they are sometimes more willing to accept some risks. So we have to consider that the use of low efficacy treatments may result in faster disease worsening and disability progression compared with high efficacy treatments. So early intervention with high efficacy treatment improves outcomes. Historically, there was the method of escalation as a common treatment strategy for MS, the start low and go slow, initial treatment with low efficacy, low risk therapies, and then switching to a higher efficacy treatment if disease breakthrough is observed. Treating early with high efficacy therapies has been emerging as a more effective strategy. And this is how we are shifting the needle, shifting our algorithms and treatment strategies into highly effective treatments early on. Initial treatment with these high efficacy therapies, with high efficacy DMTs. And this is associated with reduced relapse activity versus a later treatment initiation. And this is our latest Minactrim treatment algorithm for the treatment of RRMS. And this is being, now actually it's being modified. The panel has met recently, our Minactrim's panel has met recently, and it will be probably finalized in the summer and probably published. And it will also be more and more probably, not to say aggressive, but it will include more moving the aggressive therapies and treating early on probably more. So many of you are familiar with our Minactrim's treatment algorithm. So I just wanted to put it here to kind of remind you of it. So let's dive into the role of B cells in MF pathogenesis. So what's the rationale for targeting B cells based on their pathogenic role in MS? Clonal expansion of B cells and the production of oligoclonal IgG in the brain of and CSF of patients with MS. Follicle-like structures are formed by the B cells in the meninges of brain of patients with MS. Plasma cells are found in large numbers in subacute and chronic MS plagues. B cells are required as APC antigen-presenting cells to promote the autoimmune T cell responses in experimental models of MS. IgG is also associated with demyelination and detected in the brains of patients with MS from an early on stage. So furthermore, clinical evidence has demonstrated beneficial effects of anti-CD20 B cell therapies in MS. So CNS reactive B cells cross the blood-brain barrier, and they can be found in the brain tissue, in the CSF, and in the meninges as well. Pro-inflammatory B cells exit the chronically inflamed CNS, where they carry the CNS antigens. They present the antigen to T cells in the draining cervical lymph nodes, and there will be subsequent trafficking of these activated T cells into the CNS. So Maya has already talked about how the evolution of anti-CD20 monoclonal antibodies in the therapy of MS has occurred, where rituximab originally was partially chimeric, and then ocrelizumab was mostly humanized, 90%, and then we had ofatumumab, which is 100% human or humanized. So it's fully humanized, as we said, devoid of any mouse sequences, with a favorable, mostly favorably low immunogenicity, and it's expected thus, because it's fully humanized, to confer a very low safety risk and immunogenicity. So we will not go a lot into the detailed phase 3 studies and how they were designed, but this is just to show you the general design of the studies and how the safety period was designed and how it went on. But generally, just to compare and to show you the baseline characteristics between the active comparator, which was teriflunomide, and ofatumumab, and to show you that they were generally consistent across both trials, which was the Sclerosis 1 and 2, and to show you that ofatumumab led to a rapid B cell depletion and was sustained up to week 96. And this is how B cells have emerged as an important therapeutic target in MS. And it was showed that they were very highly effective in the treatment of RRMS. Now, this shows us that regardless of body weight, the median B cell counts were reduced rapidly with ofatumumab and were sustained at 0 up to week 96, regardless of body weight. So comparing patients less than 60, less than 70, and up to 84. It also showed us that compared to teriflunomide, and Maya has already showed this data, there was an absolute ARR was decreased up to 51 to 58% in the two studies. Now to look at the MRI data, so we will look at clinical data and we will also look at radiological data, and ofatumumab also demonstrated a significant reduction in the number of GAD-enhancing lesions. So 97% and 94% relative reduction in GAD-enhancing lesions. And now to look at T2, which is new or enlarging T2 lesions. So here we're looking at not just enhancing or active MRI lesions, we're also looking at evidence of new T2 lesions, which also shows us that there are not just, so you know that the difference is when we look at active or enhancing lesions, we're looking at lesions that have very short life, that have existed in the last few weeks. When we look at new or enlarging T2 lesions, we're looking at lesions compared to the last MRI we have done. So this is also very important information. And this showed us that ofatumumab also demonstrated a significant reduction in the number of any new or enlarging T2 lesions compared to teriflunomide with a relative risk reduction of 82 to 85% as compared to an active comparator of teriflunomide as well. Now, we also don't want to just look at clinical and radiological data from a perspective of disease activity only. We also want to look at confirmed disability progression as well. So we want to look at delaying progression as well. And that could increase the amount of time where our patients are able to work and live independently. And this is where we started originally. We were talking about how our patients will continue to be active. So the point is we want our patients to maintain quality of life. We want our patients to live. And, you know, we always tell our patients that, yes, we want them to accept the disease, have the disease as part of their lives, embrace the disease, you know. So these are as nurses, this is what we want. What's important for us is that our patients, yes, eventually we all want to cure the disease, that is true. But meanwhile, while we are all working for a cure and while we are all hoping for a cure, what we want is for our patients to be able to live with the disease, embrace the disease. So what we want from these highly efficacious medications is to let our patients live their life as though the disease does not exist. So yes, we want relapses to stop, but what we know when we look at the new concepts of smoldering disease, of PIRA, of these concepts, that even when relapses do not exist, patients will still tell you, I am not able to live my life as though MS does not exist. So yes, we want to stop relapses, but there are also other outcomes we need to look at. And these are what these studies are looking at as well. We want to look at delaying progression, delaying evidence of all those underlying things, the things that are under the iceberg, if you want. So here we can see that this anti-CD20 therapy is also showing significant reduction in 3-month and 6-month CDW. So we want our patients to be able to, as we are saying, continue to work and live independently as well. We're also looking at NIDA-3 here, and we are also comparing between ofatumumab and teriflunomide as well. And in the second year of treatment, patients who have been able to achieve NIDA, if we compare between ofatumumab and teriflunomide, nearly 9 out of 10 were able to achieve that with ofatumumab, and only 50% were able to achieve that with teriflunomide. Now, for safety, there were no major events. One death occurred in the post-treatment follow-up with teriflunomide, so no major issues in the safety category. For injection-related reactions, of course, I mean, most injection-related systemic reactions will occur in the injectable, so they were mostly mild to moderate in patients receiving ofatumumab, so around 98% were mild to moderate. So here to look at, so there were no apparent association of decreased Ig levels with or an increased risk of infections in patients receiving ofatumumab. And with this, I will end so that we don't go over time. We wanted to talk a little bit about the long-term safety and efficacy of ofatumumab. So we will talk a little bit more, hopefully, in more details and hopefully more webinars in the future. So there are some new data as well that show us more and more information about the long-term safety as well of B-cell therapies that we can also discuss more. But let's see if we have some questions before we end.
Yeah, thank you, Joelle, for this excellent presentation about this also very interesting class and target in MF that really showed very high efficacy with a good safety profile. So usually with alemtuzumab, when we tended to go higher in efficacy, we have a more aggressive mechanism of action and thus more side effect. But with really this anti-CD20, 20, we had a very balanced safety efficacy profile, and with also ease of administration with ofatumumab, since the patient can do the injection at home, and it's a subcutaneous one with a low frequency once per month. So what about its use in women with childbearing potential? So how can we plan pregnancy with ofatumumab use?
Yeah, I mean, this is also, I mean, anti-CD20 therapies have also emerged as a good option for patients who are planning pregnancy. So we don't need to really stop these therapies before patients get pregnant. We are able to allow patients to get pregnant and then stop therapy once they become pregnant. So it's a good option for people who are planning pregnancy.
And what about the baseline test required before starting a patient on ofatumumab or other anti-CD20? What are the blood tests or tests that we need to do before initiating therapy?
Yes, so generally what we do is, of course, I mean, general tests. So we do a CBC, we look at liver function tests, and we do hepatitis screening tests for these patients. So generally we look at infectious screening tests, but mostly according to the label, we're supposed to look at hepatitis screening tests.
And a final question, what about the use of vaccine with these? We know that the B cells are usually the cell that will develop immunity once we receive vaccine. So what about the use of this medication with the vaccinations?
Yes, so in general, live vaccines are contraindicated in these cases. For other vaccines, the issue with other vaccines is, as we always tell our patients, Maya, is the issue of decreased efficacy or response of the vaccine. So we have to always check whether our patients will develop the right efficacy with the vaccines. So we have to check with the timing when to give the patients this vaccine. So it's about developing the right response to the vaccine. So it depends what kind of vaccine the patients are taking. So let's say for COVID vaccines before, if we are receiving infusions, let's say we used to have to receive the COVID vaccine before receiving this infusion. So we have to check about timing. It's not contraindicated to receive them. Sometimes we used to accept for these patients to take these vaccines, but we have to educate our patients that the response will be decreased. It might be diminished. So they have to keep that in mind.
And a final question from your clinical experience and the clinic. So are patients using ofatumumab experiencing like allergic reaction that we usually see with infusion anti-CD20, like with rituximab and ocrelizumab, all these infusion reaction?
Yeah, no, we generally don't see allergic reactions with ofatumumab. We can experience, patients can experience like side effects. They can experience injection reactions, like let's say fatigue or headache or some elevation in temperature, but this can be transient and usually they are very highly tolerable. But we don't see the infusion reactions like the cytokine release that we see with the infusions usually, no.
Thank you, Joelle, for being with us tonight, for moderating this webinar, and also for managing it and contributing to its scientific program and the choice of the speakers as well. So I'm not sure if Dr. Yolanda is still with us. So we have one question about pediatric MS. Are you still with us? Yeah, so Dr. Wheeler, we have one question, so related to, is MS in children have a relationship with ADHD?
And my answer is going to be no. We see ADHD more prevalent in those children who have had ADEM and then go on to develop MS, but there's no correlation between ADHD and MS. And so I would say no, there's not a correlation between those two. But often the kids who have had ADM, who have and then gone on to develop and meet the criteria for multiple sclerosis, they typically have ADHD.
But patients like children with the MS, do they have more or they face more learning difficulties in school compared to others?
So that's an interesting question. So I just finished, I was involved in a study, a network study looking at cognition in multiple sclerosis. I was the site PI at my center. I think it was about 8 centers across the United States that were involved. And there was, before this study, a misnomer that more MS children had cognitive symptoms. So there's in the study involved pediatric patients with MS, it involved healthy controls, and it involved adults who were newly diagnosed the same amount of time that the ped cohort was diagnosed. And it was found that they had no more cognitive deficits than the peers or the adults with MS that were newly diagnosed. And so you ask a loaded question, Dr. Maya, because you have to give an account to the number of relapses that the patient has had, and if they have a deficit that's due to being out of school. We asked that question in the face and in the middle of a pandemic when kids were no longer receiving proper services or were not getting the educational needs that they needed to be met even without the face of, you know, a disease like multiple sclerosis. And so it's difficult to tell, but what we found from that study is that those kids with multiple sclerosis have no more cognitive deficits. Now, again, think about diseases like ADM, where they may have some cognitive deficits because of learning disabilities. And so you have to look at multiple factors when you're thinking about and talking about cognitive deficits when it comes to MS.
And if I can ask, what, like in general in the clinic, what do you use to assess the cognition regularly for children, for pediatric onset MS?
That's another great question. So typically what happens, even when they look good physically, mentally, if their grades are excellent, even before MS, we typically schedule a neuropsychological evaluation. And we do a battery of tests that, and I can't rattle off all of them, my apologies, but we do a battery of tests to, you know, visual, spatial, all types of tests, not just, we're not looking at IQ, but we're looking at processing, how they process information. We suggest that they do that when they're well. Now, the problem in the United States is everybody needs neuropsychological testing, so it may take 6 months before you can get into a slot. Yeah, and so I start that conversation off after the diagnosis is made. And I suggest that everybody, no matter what their performance has been in the past, whether they're straight A student, honor student, I suggest that they have neuropsychological testing, because I tell them that it's not, we need to pick up when they're well and when they're performing at their highest level. And it may take a while to get in. Yes, we establish a baseline, and then we do follow up every 2 years. I will do follow up if I feel like a patient has had a significant cognitive hit. We'll do another one in between there.
But I mean, we generally use like the SDMT for everyone, for all MS patients. But,
yes.
I'm wondering if
we do SDMT with our patients for every visit.
Yes, exactly. But I'm wondering if it's I mean, so we do it for our pediatric patients as well, but I'm wondering if it's not as reliable maybe, or, you know.
Nobody's looked at that.
I know.
You know, the cognitive test will pick up on subtle things like
Yeah.
processing information, especially when I'm trying to help children seek accommodations, because it's not that they don't know the information, it's the speed in which they process the information.
Exactly.
And so they have longer time on tests. And I can write that letter to the school saying they need extra time on a test because they're not processing speed as fast as their peers would be. And so the SDMT may or may not be picking up on those type of things. Somebody that has visual issues may need accommodations for visual impairment, such as enlarged textbooks. So the neuropsych testing would pick up on all that information that may not necessarily be picked up on an SDMT.
Right. So you have to accommodate for different, needs or abilities. Yep.
Exactly.
All right.
And that would be a great topic for me to talk about.
Yes.
Yeah. During our next webinar, definitely. Definitely.
Yes. That's a fascinating topic that a lot of clinicians don't know what to do with.
Yeah,
Yeah.
true. Very true. So with this, our webinar today come to its end. So let me thank our moderator and speaker, Mrs. Joelle Massouh, for being with us tonight, despite her super busy schedule. Dr. Yolande Wheeler also for joining us all the long from the USA, despite the difference in time between here and there. So thank you so much and for staying with us until the end of the webinar. Also, Mrs. Gina Lee, thank you for accepting our invitation. The big thank you goes for our almost 200 attendees tonight. So thank you so much for attending our webinar. Also, allow me to thank our sponsor, Novartis, who supported this educational activity, and the Consortium of Multiple Sclerosis Center for always on encouraging such educational webinars. So thank you so much all of you for your support. Finally, I would like to remind all our attendees that they will receive their certificate of attendance within 1 week from today by email. And if they missed any part of the presentation, or any one of you would like to revisit the lectures or relook at the presentation, that can, as Joelle mentioned, check our IVPN library, which is currently still available free of charge, where you can revisit all the webinar. Also follow us on our social media platform to always know about our weekly educational activities. And you can meet us tomorrow. Actually, we'll have a different kind of we'll discuss a different topic, which is treatment resistant depression. But also depression is one of the common symptoms that we see in our MS patient. So meet us tomorrow also at 8 p.m. to discuss treatment resistant depression, the new therapies, and all the pitfalls in managing this disease. And until I meet you again, stay safe and have a good night, everybody. Thank you so much.
Thank you.
Thank you, doctor. Bye-bye. Bye.
Bye.